I think we may start. Colleagues, good afternoon, good evening, and good morning, wherever you are. Welcome to this webinar titled Adolescent Service Integration, Lessons from Adolescent Sexual Reproductive Health, and VMMC Linkages Project in Zimbabwe. This is a case-based learning. My name is Dr. Fabian Ndenzako. I work with the WHO in the regional office. I'm a medical officer in charge of HIV, TB, and hepatitis in the Eastern and the Southern African sub-region. I will be your webinar moderator today, and I really thank all of you for joining and participating to this webinar. The webinar will focus on a very important topic on service integration for adolescent health and HIV services. Like we know, adolescent sexual reproductive health and voluntary medical male circumcision programs have long been implemented as a vertical national health programs, not complementing each other in improving service utilization. It is important that we begin to close this gap and work towards efficient integration of adolescent services. Second, I think some of you may as well recall that at the global VMMC guidelines dissemination meeting in August this year, one of the areas people highlighted for further discussions was on adolescent service integration and the VMMC as an entry point. This webinar therefore gives us a step forward in that direction. The presentation and the discussions will highlight the smart linkages project in Zimbabwe, including cross-referral mechanisms and bidirectional linkages of adolescent boys for VMMC and adolescent sexual reproductive health services. This presentation and the discussion thereafter, we hope will allow the country learning and the sharing of challenges and best practice solutions for integrating adolescent services with the VMMC and adolescent sexual reproductive health. So the agenda today, we will have greater presentations, again from the Ministry of Health in Zimbabwe on the integration project. We will also have an opportunity to have some group discussions and come up with some key actions on integration. Just before we start, I'll be taking you through the housekeeping notes, and I would also encourage participants to really turn on your cameras as well so that we can see who is on this call. If you can move to a slide on the housekeeping, please. Yes, so please, if you have any challenge, chat with the ECHO IT to troubleshoot any Zoom problem that you may experience. And just to remind all of us that we need to enter our proper name and organizations that to, and also that the presentation slides and the link will be shared by email for those who registered after the session. And this session is being recorded, and your attendance is consent to be recorded. And I really thank you for that. Next. Now, the last slide on the housekeeping, just to obtain a certificate of attendance. I'm sure some of you who were on the August launch of the guidelines, you had your certificate. You will need to fill out a short survey. We will provide a link in the chat to access the survey near the end of the session. The link is accessible for the next 48 hours only. In regard to the data use, the project ECHO collects registration, participation, questions, answers, chat comments, and poll responses, which will be shared with the WHO Afro. Your individual data will be kept confidential. This data may be used for reports, maps, communication, survey, quality assurance, evaluation, research, and to inform some of the new initiatives that we may think of. Next. Now, let me take the opportunity to introduce Julie Samuelson. The name is many of us. She works with the WHO headquarters, and she's the focal person for VMMC program in HQ Geneva. She's going to provide remarks and community of practice. Julie, you have the floor, please. Over to you.
Thank you, Fabian, for the introduction. So my remarks will focus on the first 3 words of the title of this webinar. And I thank the Zimbabwe team for sharing the ASRH VMMC Smart Linkages project. So the first word is adolescents, who are defined as those aged 10 through 19 years. And many of you, of course, are familiar with a lot of these points, but I think it is good to just be on the same page. These adolescents make up a large and growing proportion of the population in East and Southern Africa. This age range spans a critical period of human development with rapid changes from the physical and hormonal, including sexual and reproductive maturation, to psychosocial, cognitive, and emotional changes. Adolescent health needs are diverse and context dependent. In Southern and Eastern Africa, among adolescent boys, HIV is the cause of about 50% of years of life lost. Top risk factors are unsafe sex and alcohol use. Limited knowledge, gender, and masculinity norms underlie these risk factors. Unplanned pregnancy and sexually transmitted infections are sexual reproductive health problems also experienced by adolescent boys and girls. Prioritizing adolescents in health services builds on global current commitments and strategies. It's known that investment in all aspects of adolescent health, education, and engagement yields social, demographic, and economic benefits for the whole of society, including for adolescents now, later in their lives, and for the next generation. The second word of focus is services. Next slide, please. As part of combination HIV prevention, VMMC is a proven effective intervention. A package of VMMC services has been offered to adolescent boys and may be one of the first times these adolescents have had contact with any kind of services in the health system. When delivering MC services, the opportunity exists to offer other needed services. In the new WHO guidance, which is shown, the cover is shown here on the left, Chapter 3 indicates other evidence-based interventions recommended by WHO. Chapter 6 looks at sustaining VMMC services with a focus on adolescents. And critical enablers in that chapter point to co-production with adolescents, local ownership, community engagement, multi-sectoral partnerships, and enabling policies. And an example of this is provided in Annex 6.1, which is the Smart Linkages project. The third word is integration. Next slide, please. As mentioned by Fabian, VMMC services have been delivered mainly through vertical approaches. Service delivery models that are embedded in and coordinated across routine health systems are limited. This gap can be filled by exploring and identifying which services to offer and how to deliver them. Since 2013, Zimbabwe has explored SRH and MC integration using a participatory learning approach and program-based monitoring. Now is an opportune time to move forward together as integrated adolescent services fits in with local and global goals. For World AIDS Day next week, WHO is emphasizing global solidarity for resilient, sustainable services, including to expand coverage of needed services to adolescents and to innovate service delivery. Solidarity is enhanced through local to global learning, mentoring, and engagement. Today, after the presentations, participants will discuss in small groups. One way to continue this sharing is through communities of practice. Communities of practice could be multi-country or for individual countries. With the technologies now available to most individuals, virtual community of practice have become our new way of working, but they are efficient and they are a timely approach to hear from more people together, and in particular, those who are delivering services, facing challenges, and finding innovative solutions. If there is an interest to go further with a virtual community of practice, WHO and Project ECHO are ready to support such communities in the transitioning to resilient services for adolescents. Thank you.
Thank you, Julie. May I request the colleagues in the ECHO to project the Zoom poll? So we have a question here, of which I would request each of the participants really to fill in. It's very simple. The question is, in your country, how would you rate the progress towards the integration and the linkage of adolescent sexual reproductive health and VMMC services? So we have 3 responses, whether it's at early, intermediate, and advanced. So in your country, you know your country better than anyone else. How do you rate the progress towards the integration and the linkage of adolescent sexual reproductive health and the VMMC services? So you choose one of these, either whether it's early stage, intermediate, or advanced. So we'll come back to see the responses. Let me now take the opportunity to, next slide. Let me take the opportunity to introduce our next speaker, who is Talent Makoni. Talent is the Adolescent Sexual Reproductive Health and VMMC linkages officer in the HIV and TB unit within the Ministry of Health and Child Care in Harare, Zimbabwe. So Talent will take us through the case presentation on an overview of the Smart Linkage Project in Zimbabwe, Part 1. And Talent will have 10 minutes for this Part 1 presentation. So Talent, you have the floor to take us through this case presentation.
Pleasant day to you all. I'm greatly honored to be representing Zimbabwe as we share lessons from the VMMC ASRH Linkages Project, affectionately known by the young people as the Smart Linkages Project. I'll ask for the presentation to begin. Next slide, please. So that's the outline of my presentation. So part one will mainly be an overview of the processes and core elements of the project. And part two will be the juicy part, if I must say, where we'll share project evaluation results and the challenges and the lessons we learned from this journey of integrating ASRH and VMMC in Zimbabwe. Next slide, please. So as Julie has alluded to earlier, our young people across Africa particularly are disproportionately affected by HIV. It's a cause of concern for everyone. And we cannot walk this journey alone. We be partners, funders, programmers would really need to work together and focus on the young people themselves in order to really reach epidemic control. WHO, as earlier on shared, different documents are available at our disposal for linking, which recommend linking VMMC and ASRH programs and services. Of particular importance would be the programmatic option support material, which speaks clearly and guides on the linking of VMMC and ASRH programs. Next slide, please. Coming closer home, integration and linkages of health services is a top priority for the Ministry of Health here in Zimbabwe, as clearly spelled out in the mission statement of the Ministry of Health and Childcare, which seeks to provide comprehensive services in a more holistic and quality, in a more holistic and quality manner for its citizenry. So support from the leadership was really availed from the get-go for linking the two programs. A series of preliminary consultations were conducted between 2013 and 2014, of course with funding from the Bill and Melinda Gates Foundation, the US CDC, and World Health Organization. Key organizations included the two units within the Ministry of Health and Childcare with a mandate, one for HIV and the other one for reproductive health units. That is the ATP and the reproductive health unit. And World Health Organization as the technical and funding partner. The Zimbabwe National Family Planning Council played a critical role as an ASRH technical lead within the country. The Bulawayo City Council, PSI, amongst other key community-based organizations and NGOs were pivotal to the success of this project. Next slide, please. So making a compelling story for any project requires the buy-in of all stakeholders, and the VMMC ASRH linkages was no exception. So the following rationale was to be understood by all stakeholders from the get-go. The investment case that demonstrated VMMC as an important high-impact HIV prevention intervention. The unprecedented contact that VMMC has with adolescent boys, and the importance of taking advantage of that contact. The complementarity and reinforcing nature of the ASRH and VMMC linkages in providing entry points to one another. And most important was the need to get everyone on board and everyone appreciating that linkages and integration is really in everyone's best interest, from the policymakers, the funders, the programmers, the health workers, and the adolescents themselves. Next slide, please. So the objective of the project was really to assess the feasibility and capacity strengthening requirements to enhance ASRH and VMMC integration and/or linkages in order to inform transition to longer-term VMMC strategies and services, along with the gender transformative intervention. Most emphasize, along with gender transformative interventions. So the project scope spanned over 3 phases. The first phase really was a preparatory groundwork, which enabled understanding of the 2 programs and selection of sites. The second phase was implementation, which sought to demonstrate the feasibility of linkages before scaling up. And lastly, the third phase, which was really implementation, research, and evaluation. Next slide, please. For the core processes of the project, it was very critical to be clear from the get-go. So the current state of VMMC and ASH programming really needed to be scrutinized further. The strengths and the weaknesses in the different service delivery mechanisms were to be interrogated. The gaps within the 2 programs in terms of linkages were really to be spelled out, and key steps to bridge these gaps informed the action plan, which was later followed. Different health facilities and youth centers working modalities were to be well understood, and the referral mechanisms as well. Next slide, please. For the core elements and options of packages for the integration project, 3 packages of interventions were considered. A minimum package, which essentially was provision of essential information for ASRH and VMMC, VMMC services. And then from a basic package was the next level of service, which really sought to avail clinical services for both VMMC and ASRH. An extended package, which was the most ideal, the ideal of packages, really sought to provide broader, more broader interventions, more broader than just the information and the clinical services, which would really go into the social and behavior change communication, gender, sex and gender, and gender transformative masculinities, amongst other social and behavior change interventions, which are critical for the adolescents. 4 options were availed and considered for consideration. Option A, which really was a service delivery of both ASRH in one facility by one provider. But as we all know, when we look at different health service systems, it's not always feasible. So we had another option to consider, which was service delivery of both ASRH and VMMC in one facility by different providers. That was our option B. Our option C included option B, but also took into cognizance our different geographical settings and state of accessibility of our services, which would then incorporate each service delivery models like outreaches. Option D, here we're looking at the different facilities, different organizations really coming together, and different providers referring and linking adolescent boys across the referral pathway. Next slide, please. This is just a diagrammatic schema of what I've been trying to explain, that we had a minimum package for other services, for other sites, which were in no position to provide a more holistic package of services. For those that could avail clinical services that were in our basic level of package. Ideally, we would have loved to have all our sites offering expanded package of services. Next slide, please. So a number of consultants were selected to really work on the project baseline from April to December 2014. And their role was really to map the current configuration for the 2 programs and select project sites. And 2 project sites were selected. That was Mount Darwin District, which is a rural district, and Bulawayo City, which is a metropolitan province. The 2 were selected on the need to really get a more broader, a more richer learning experience when it comes to linkages and integration of ASRH. Another important deliverable for the consultant was development of messages for the joint messaging for the two programs, and development of appropriate service delivery protocol and menu of options. These were then field tested, the protocols were then field tested for their appropriateness. Next slide, please. So key findings from the baseline revealed that there was a parent skills gap, which was obvious, and young people were not being effectively linked to community models, through community models, and this needed to be strengthened. Messages were available for the two programs, but never jointed messages that provided a more holistic approach to adolescent sexual reproductive health. Social networks were deemed popular among young people, and these were recommended for further evaluation within the project scope. And our consultant developed service delivery protocol and menu of options based on the 3 packages I've earlier on alluded to. Next slide, please. So from 2016 to 2017, a number of interventions were tested within the project sites, which included the effectiveness of enhanced capacity building for health workers and staff and other staff, use of social media, joint demand creation and service delivery, use of referral slips for cohort-wise monitoring, IEC materials with joint ASRH messages, the use of the U-reporting platform to really understand the different perceptions of young people when it comes to different interventions that are offered to them. A seed fund initiative was also tested. Here, the different youth centers were availed with a seed fund to really implement development projects within their youth centers. Positive masculinity manual was developed, and use of community dialogues in communicating VMMC and ASRH messages was also explored and tested. Next slide. So the third phase of the project was really to understand if we're making any headways when it comes to smart linkages. So evaluation and gender transformative work would then fit in perfectly within the third phase. Research protocol development was one deliverable, and the research evaluation was conducted through a sorted course over a year period from a more scientific, rigorous method. Gender transformative work resumed within the third phase with the aid of a draft masculinity manual, and qualitative research on the project was also commenced to get a more in-depth and rich understanding of different aspects affecting the project and the adolescents themselves. Next slide, please. So expert consultants were hired for the manual development, inception meetings, data was collected, and the data was then analyzed. When it comes to positive masculinity, was then analyzed using themes and actual content. An independent organization that really works on gender in Zimbabwe was hired as part of the draft revision and control of the positive masculinity manual. To date, we have over 300 community-led community dialogues on using at this point. I will pause for a minute, for a moment, before getting into the actual evaluation of the project and sharing of the lessons learned from the project. Over to you, Fabian.
Thank you very much, Talent, for sharing with us the project inception and all the phases that it went through, but also more important, also the engagement of other stakeholders, but also targeting really young people for HIV prevention. So before we move to the part 2 of your presentation, let me take the opportunity to invite other stakeholders who have been part of this project to really share a reflection with us. I will start with the Mr. Gumbo. I'll start with Mr. Gumbo, who will share with us. It's from the Zimbabwe Family Planning Council. Mr. Blessing Gumbo is the provincial manager, Zimbabwe National Family Planning Council. So Blessing Gumbo, you will have 2 minutes to really share with us your reflection on this presentation. You have the floor, Mr. Gumbo.
Thank you, sir. Good day to everyone. Basically, I would like to share some of the important elements to consider when integrating adolescent services. So I'll highlight 5 key elements in the integration of services for adolescents. Point number 1 will probably be access to information. Young people need to have access to information. And we've noted in the implementation of this program that most of our young people are using WhatsApp out to them with information so that they are able to make informed decisions around adolescent health. So the issue of access to information is number 1. And point number 2 to consider is the issue to ensure that there is relevant information, education, and communication material that young people can relate to. And I've noted through this program that there are posters, there are pamphlets that have local people. So these young people then feel they can own the program because they are seeing some of them that are part of this particular program. So they feel they are a part of it. They feel they can own it because they actually, there is a reflection in terms of the relevant IC material that is local. And also the issue around proper signage, still under relevant IC material. Young people actually want this sketchy material that they are able to relate to. The third point that I want to speak on is around the issues to do with continuous capacity building of peer educators and service providers so that they are in sync with the current adolescent health needs and trends. The young people and our service providers are abreast with youth-friendly services and information that is current and that is relevant for young people. And point number 4, I'll speak to young people, parental guidance and community leadership. So these young people, these adolescents are part of communities, and in the communities, they live with parents, they live with guardians. They also subscribe to different community leadership activities. They might be part of churches, they might be part of social clubs where they are leaders in those churches. So involving these local leadership, involving the guardians, involving the parents in parent-to-child communication and comprehensive sexuality education is key in ensuring the sustainability of the program and also in encouraging young people to access the services. And finally, point number 5, I'll speak on availability of medical sundries, availability of drugs and diagnostic equipment to ensure that these adolescents continuously are able to access services. I think with that, I'll stop here for now. Thank you.
Thank you, Mr. Gumbo, for the 5 key elements. They're really very useful. I think these are really key to many of the programs. Now, let me invite Dr. Leslie Bite, who is the Regional Manager, PSCI Zimbabwe, to also provide your reflection to the program. Leslie.
Hi, thanks, Fabian. I think as PSI, we can't overemphasize the need for commitment from both VMMC and SRH program to ensure successful bi-directional referrals. One of our sites we've been involved in this project is that now Zimbabwe's second largest city, and the linkages project has been quite successful. We've been referring all our VMMC clients to SRH and vice versa. And the completion rate was above 30%. In the site, which has really been successful, we had the VMMC services and the youth centers where SRH programs are being offered, located in close proximity to each other. And this emphasizes the advantages of co-location. If you have all the services co-located, it brings convenience to the adolescents. They get the services in one area, and we have successful linkages. The other important thing is enhanced support to the healthcare providers. It is very important that we emphasize the advantages of integration and bringing all the services in one place, and the importance of providing comprehensive care to the adolescents. So the program has been really successful in those areas. We've also been participating in this project in the rural districts, and in those places, there's been also bi-directional referrals and demand creation levels. We have demand creation agents in various areas in the district who would refer for VMMC and SRH and vice versa. And the program has been working quite well. So I think in conclusion, the important things are co-location of services, education to the healthcare providers on the importance of comprehensive package, and also emphasis to community health workers who include the mobilization agents. I think in summary, that's what I have. Thank you.
Thank you very much, Leslie, for sharing the ground experience in both urban and the rural settings, and some of the key ingredients that are really required for the program to work. Now, let me move to Dr. Webster Mavu, who is Program Director, Center for Sexual Health and HIV/AIDS Research in Zimbabwe, to also give his reflection. Dr. Webster, please, you have the floor.
Oh, thank you very much. So I'll speak from the point of view of a researcher. I've been conducting research to inform VMMC implementation in Eastern and Southern Africa. And we conducted a study to look at these issues, how VMMC was a missed opportunity for other interventions and the potential to link VMMC with SRH. And we specifically included these sites that were part of this project because we wanted then to see if our findings could then compare. One thing that we found out that was around 2015 to 2016, and we later published a collection of articles in clinical infectious diseases. I will share the link, was that VMMC was really a missed opportunity for integration with other services. And although the VMMC package includes several components of SRH, these were not always applied in the same manner. One key issue that emerged among providers, VMMC providers, was that they lacked their adolescent-specific training. And largely this is because when VMMC started, it was meant to target adult men who were sexually active. Now, when they were then applying this intervention and this messaging to adolescents, it was kind of they were not very sure which messages to give and which ones not to. So they wanted adolescent-specific training, and the other one, they also wanted standardized messaging, especially around disclosing an HIV positive result to an adolescent, whether they were supposed to do that without the caregiver or parent present, or they were not sure what they were supposed to do. The other thing was they were not very sure whether they should give sexual different messages to sexual experienced adolescents, especially for younger adolescents. Now that the Zimbabwean VMMC program is going to focus on at least those that are at least 15 years older, that won't be an issue. But then, because they were dealing with young adolescents, that was an issue. But I like the fact that this initiative also included the gender transformative approach, and this is in line with the global trends. We know that WHO recently commissioned some systematic reviews to see which gender transformative approaches could be applied, especially with adolescent boys, and how we could move this forward. So this is in line with what's happening. Thank you.
Thank you very much, Webster, for also your observation and the reflection. I may understand that at the moment, perhaps some of you may have some questions that you want to ask. I would encourage actually to use our chat box now. But before I open up for the questions, let me allow Talent Makoni to finish her second part of her presentation. Talent, please, if you can take another 8 to 10 minutes to go through the second part, and then I open up for the questions. Talent, you have the floor.
Thank you, Fabian. Thank you very much. So my second part, like I've earlier on, will really highlight on the project evaluation, the lessons learned, and the next step. Next slide, please. Okay, so how smart were the smart linkages? Next slide, please. So from January 2018 to May 2019, the project evaluation process commenced through the sorted course from protocol development to publication. 3 cohorts were followed up for 3 months from both ASRH and VMMC end to determine the proportion linked to either services. Routinely collected secondary data was analyzed to assess the effectiveness of service utilization and the proportion and linkage and the rate of linkage. Data from peer educators' monthly statistics was validated, analyzed, and peer educator workload and role was ascertained. The financial position of the project was also evaluated through the financial records to measure its sustainability. In the end, 4 research papers were published in various journals. The links will be provided in your references at the end. Next slide, please. So in summary, the project evaluation demonstrated the feasibility of linking the 2 programs and its cost effectiveness. Utilization of services significantly increased during project implementation compared to periods before implementation. This was demonstrated in the number of cases of clients that we attended to in both the ASRH and VMMC end, the number of STI cases screened and treated, uptake of family planning services, and the actual number of referrals between institutions, which before were not even linked at all. 31% linkage rate was noted from VMMC to ASRH, and a 33% linkage rate was demonstrated from ASRH to VMMC linkages. Please note that before, there was no way of tracking VMMC and ASRH referrals if they were there at all. Evidence was generated on the complementarity and reinforcing nature of the 2 programs, as seen by the different joint demand creation and service delivery pursuits that were explored. Analysis of financial records showed that money matters. Money matters for success. However, to cut on project cost, there were options that we actually investigated on the utilization of non-monetary incentives and implementing programs that were rooted in the community, such that the cost per activity was really lowered. How important are peer educators? I'm sure there are a number of publications that have questioned the effectiveness of peer education as a concept. In the project, peer education was demonstrated to be very efficient by an 86% proportion of all the referrals that were made being reported from the peer educators. Next slide, please. What were the challenges? What were the challenges that the project made? In our urban sites, the use of user fees actually limited access to clinical services for adolescents. Most of them are unemployed, probably in school, and under parental care, and in no way would not have funds available to them for treatment of STIs or something along those lines. A lack of proper infrastructure in some youth centers, limited reach, and due to the pilot nature of the project, our indicators for referrals could not transition to the national M&D system, as it was just a pilot project for 2 sites. And access to geographical inaccessibility of some rural sites actually led to a low follow-through on peer educator referrals. Next slide, please. So much of the challenges, what have we learned thus far? We've definitely learned that integration and linkages should be undertaken from a system perspective. When we're developing our menu of options, this was really critical to the success of the program. There was no way of inventing any new structures. So using existing resilient systems actually led to the success of the project. Collaboration and partnerships is pivotal and key to sustaining adolescent sexual reproductive health, linkages to adolescent sexual reproductive health services. Inclusion of community leadership, youth participation remain as cornerstone for strengthened ownership, linkages, and sustainability of the linkages project. Various service delivery models need to be informed by context-specific issues. The issues that affected rural Mount Darwin were really different from those that affected Bulawayo. And from the get-go, it was critical to take those in cognizance when drafting interventions or when testing them. Next slide, please. Peer educators, they're really pivotal. They facilitate referral and foster peer-to-peer counseling. There is improved accessibility and coverage of services when we also incorporate outreach services for our peripheral remote public health services. Person-centered solution and enhanced sustainability. How so? When individuals that we undergo through individual counseling, we're more likely to get to be completely linked to either ASRH or VMMC, speaking to the need of a person-centered solution when working with young people. Don't just group them and assume that because you've talked to them on a group education, they'll filter through to the other service which you are referring them. Take them as individuals, person-centered solutions. Co-location of ASRH and VMMC services, I'm sure Dr. BD has already alluded to this point, is very critical and plays a really pivotal role in strengthening linkages, particularly in Bulawayo, which was, in this case, it was feasible to do co-location of services of ASRH youth centers and VMMC centers, as they are just adjacent to each other. Next slide, please. Enhanced training, like Mr. Gumbi has also alluded towards, is a requirement to meet the capacity building gaps that otherwise exist within our health system. Cohort-wise monitoring of records facilitates effective monitoring of performance of the referral system. Social media, I need not belabor you. It's critical when you're working with young people in this generation. Next slide. Is the project scalable? From the project evaluation, the project was deemed scalable based on the 9 attributes that are recommended by WHO, which include credibility. The evaluation process is really credible and was observable. The ease of transferability of the intervention is also another critical attribute, which speaks to the scaling up strategy of the Smart Linkages project. So we, as a country, anticipate gradual scale up of the intervention and proposing continuing to learn lessons from the different sites. Partnerships are pivotal. We foresee a situation where we'll have more partnerships and more collaborations within our project, and learning from taking guidance from the AHA from the AHA document. There is need to include within the project implementation school health services as well as community-based platforms for service delivery. Next slide, please. Where do we go from here? We foresee the project evolving and being positioned as a holding ground for our 10 to 14-year-olds before circumcision. How we treat these 10 to 14-year-olds is critical, and the project provides for a holding bay where young people between 10 to 14-year-olds can really be informed and guided when it comes to matters of adolescent sexual reproductive health before they actually make a decision for circumcision at 15. So phased rollout is in the pipeline already. We have introduced the project and we're in the process of mapping the project in 3 additional sites, and implementation of a modified intervention in these sites would be used. Strengthening and new partnerships will definitely be formed, and there is need to continue through with the process of validating the positive masculinity manual so that we can share it across different provinces in Zimbabwe and even across our borders, and focus on reaching adolescent boys and girls that are hard to reach by any standard, be it sexual orientation, disability, geography, religion, is really another focus of the project going forth. We seek to reach all young people, disregarding their orientation, where they stay, and what they believe in. Next slide, please. I wish to acknowledge all the people listed on the slide, but even many other that I could not really put their names onto the presentation, because a linkages project speaks to a number of people that are critical, that are important for its success. Next slide. At this point, I'll hand over back to Fabian for the questions and comments section.
Thank you very much, Talent, for really taking us through this interesting project from the start, from the phases, up to implementation, evaluation, some of the challenges that you have shared with us, but also lessons, and where do we go from here? I don't want to repeat them, but I'm sure colleagues or participants on this webinar, they have noted some of the issues that they would like to raise. I think this is really the moment to do so. You can raise your hand so that you can be given an opportunity to speak out. I have also seen from the chat, Esther has asked a question. What was your experience with the education institutions with this project, if any? There was also another question from Vusi, if Bill and Melinda Gates was willing to fund a similar project targeting 10 to 14 years in VMMC priority countries. Perhaps while we are waiting, maybe more questions, perhaps you could start with the, to get some responses on this. So Talent, or perhaps other colleagues from the partners, if you can maybe, give some responses to these two first.
Okay, if any of my colleagues want to take any of the questions, please kindly do so. So I'll answer the first one. How was the Ministry of Education involved in this? So we had, through our community dialogues, included what we called the Boys and Girls Forum meetings. These were really cited within the schools. And this is where we really had our sex and sexuality sessions and positive masculinity sessions. So yes, through the comprehensive sexuality education for the in-school program, the project rided on that initiative to actually introduce positive masculinity and sex and sexuality issues within the schools for the different age groups, which are school going. And in terms of funding, whether Bill and Melinda Gates Foundation is willing to fund similar projects for the 10 to 14 elsewhere, I'm not sure of the funding mechanisms, but I know that they were funding through the World Health Organization. Direct contact with the Bill and Melinda Gates Foundation was not the Ministry of Health, but really it was through World Health Organization.
Thank you.
I think the best place to answer the question.
Thank you, Talent. I think there is, what was the SRH package provided to the 10 to 14 years for the project? This is another question. We would need to explore the Bill and Melinda Gates funding. I think this is the response coming from Jolie. So there is a question here. What was the SRH package provided to the 10 to 14 years of the project? Any idea?
The package included a number of critical issues affecting young people, such as bullying, violence, in-school violence, life skills training, which included negotiation skills, enforcing communication skills, basic HIV and VMMC information, issues to do with stress that's appropriate to their age and how to handle stress, issues to do with puberty, issues to do with okay, I can't think of any, but it was really a broad range of topics that are age appropriate for the 10 to 14. I don't know if Mr. Gumbi, who is our ASRH expert, wants to elaborate on other topics that are within the ASRH manual that is used within the project scope.
Hello, maybe can unmute, can you unmute and speak? Okay, I can't see the responses coming out. I have a couple of questions also I wanted to ask. Number one, I wanted to know whether the project provided any other services apart from VMMC and adolescent and sexual reproductive health. If a young boy comes and there are other needs as well from these two services, how did the project handle it? That's number one. But also number two, I wanted to check, for example, if say adolescent boys, some of them may have their girlfriends, whether they were allowed maybe to come with them to get some services as well. Lastly, I wanted to know the funding envelope for this project. I think one of the things you mentioned was money matters. If somebody wants to start or initiate a similar project, what was the funding envelope that you would consider? Over to you.
All right, I'll ask Dr. Mabaya, who was the lead researcher on the Money Matters evaluation question, to take the last question. Dr. Mabaya, if you can please avail to the House how big the envelope was. And then our youth centers are really friendly to the young people. Should a boy and a girl walk in and demand services, they would get them, the pair of them together. I don't know if that answers the second question. And the first question was, what other services were they within the project scope? So the first important milestone within the project was mapping of the different sites. So the mapping exercise included identification of all other adolescent health related organizations and NGOs and CBOs that are within the project. And those were reached out for partnerships and networks. And their locations, there was a common development of a director of services for the district, which all the other organizations which deal with young people were encouraged to use and refer vice versa from one organization to the other. Say it's a child who's been violated sexually, a referral would be issued to that client from the ASRH end to probably the victim-friendly unit, which was a key partner within the project scope. So linkages were not just ASRH, youth centers related and VMMC health services centered, but also included other organizations working with young people. In that way, would really provide comprehensive services to our young people.
Thank you. Mabaya, are you ready to respond?
Yes, thank you, Fabian, and thank you, Talent. So I will not be able to give figures exactly, but because I think maybe the figures would be a little bit contextual depending on each of the countries. But I would say that I think the biggest cost for us were to do with the initial setup of the project. So we had, for example, staff who were trained in VMMC, but not trained in SRH, or trained in SRH and not trained in VMMC. So we spent quite a bit on getting these people to be trained. We developed IEC materials. So we had SRH IEC materials and VMMC IEC materials. So we developed IEC materials which had both VMMC and SRH messages. And that was one of our initial costs. But I think once we went past that stage, the cost of running them, they went They came down. We remained mainly with the allowances for peer educators, which were paying in about $15 every month per peer educator, and also the salary for the person that we had seconded to Ministry of Health to coordinate the project. In terms of funding, I think one thing which I might want also to highlight is that as most of us would know, that the VMMC program is quite well funded, and we did leverage on that in terms of training, because they were conducting trainings. They already had a system in place for trainings. They already have trainers, so we sort of leveraged on that strength within the VMMC program to be able to implement this. Thank you.
Okay, so I don't see another hand or other questions and any comments. I think at this juncture, let me again thank Talent, Makoni, and your other colleagues, partners who have worked together lately to implement this project. I would now take this opportunity to invite Wole Ameyan to take us through the group work arrangements. Wole, please, you have the floor.
Right, thank you so much, Fabian. And I have to say, just really a fantastic presentation by Talent. And I can see also from the chat box, there's a lot of, there was a comment about, what do we do for the 10 to 14-year-olds? Seeing that the recommendation is, is now tilted towards more than 15 and above. And I think this is the sort of discussions we need to be having. These are the sorts of experiences and projects we need to see how we can, certainly provided combined, integrated, interlinked ESRH and VMMC services for those who need it. So I think from now, the question is always, so what next? What do we do with this information? What is the next step? How can we, make sure that we continue to promote and advocate for meaningful services that are integrated in a way that can serve adolescents and young people best. So to do that, we'll be going into group work. So we would like to, have us into groups to discuss what are the critical actions, what are the critical elements we need to take to be able to, have improved integration. And I can see, from the participant list here, there's a lot of country experience that we can have from the groups, to support these actions. Now, we will be divided into 3 groups, and you can see on the screen the three facilitators for the groups. So one group will have Dr. Simba Mabaya, who just gave a comment just a couple of minutes ago. He would lead one group as the facilitator and present and rapporteur. The next group will be led by Dr. Christine Kisia. So Christine Kisia is from the WHO Kenya office. She will be leading another group. The last group will be led by Julie Samuelson. So Julie Samuelson, gave the opening remarks, and she has agreed to step in for Dr. Laston Chitembo from WHO Zambia, who, due to unforeseen circumstances, couldn't make it. So that's the first information I'm sharing. We will have 3 groups, and Team ECHO will be able to, sort of disperse us into those 3 groups. On the next slide, please, if you can move to the next slide. Thank you. Right, so what are we going to come up with? For each of those groups, we will have 40 minutes. So this is really, we're going right to the heart of it. We're not messing around at all. We have 40 minutes, just 40 minutes to look into how to promote and improve the integration of VMMC and adolescent sexual and reproductive health. What we're coming up with are 3 actions to start. So if we're proposing, we need to start some actions if we want to promote these integrations. What are the 3 actions that your group will propose that we need to start that hasn't yet started yet? What are the 3 actions that are currently happening, but we feel they're not in the best interest of this integrated services that we're talking about? So what are the 3 actions to stop? And then finally, the 3 actions that are currently happening in some ways, but we need to continue them. We need to give more visibility to them. So that is the task for the 3 groups. We will come up with 3 actions to start, 3 actions to stop, and 3 actions to continue to improve and promote the integration of adolescent health services, including VMMC and ASRH. So that is our task. I hope it is clear, but if it is not, our facilitators will be able to provide further details in your different groups. Just to say as well that the facilitators will take, just quick notes, nothing too detailed. We just want those 3 actions for the 3 themes, and they will present to us after we come back. So we have 40 minutes, not more, not less. So I would ask Team Echo, if there are no questions, to disperse us into the 3 groups now.
Yes, we are starting it now. Kindly give us 2 to 3 minutes, and everyone will be assigned to the respective breakout rooms. Thank you.
Okay, so we have 2 minutes to spare. And I can, I'm seeing something on, the global standards for adolescent health. Okay, I think it's starting soon.
They have just got the request for the breakout room. They can join the room.
Right, so you can join, just click join and go into your rooms now. Thank you.
I'll request all the participants to accept the breakout room invite. You will see a small screen, a pop-up on your screen asking you to join the breakout room. Please click on the join button and you will be assigned to a respective breakout room. A group activity is on its way, so kindly join. You'll be getting a pop-up on your screen. Please click on join and you'll be assigned to a breakout room.
Just to let you know that group 3, I think is pretty much back in the large group. I see a number of the people who were in that group. So I think they've made it back.
Yeah, I also think that group 1 colleagues are back in the main group.
So it looks like we're mostly here. Maybe we can go ahead and proceed, either Wally or Fabian. Thank you.
I am told automatically we will be reconnected back into the main group.
Sorry, Fabian, who are you waiting to join back in?
No, I think from the chat here, I was told, will be automatically brought back into the plenary.
Right, so I think group 3 is pretty much all back. And Simba, it looked like it. Bruce is giving a thumbs up. I think everyone is back.
I think group 2 members, most of them are back too.
Okay, so should we continue with our program?
Yes, please.
Okay, so thank you so much. And again, welcome back to the plenary after the group work. It was a very interesting discussion. I happened to participate in one of the group. It was very, very encouraging, the discussion that came out. I'm sure you will hear them from, the feedback from our team lead. So for now, before I invite the group leads to provide their feedback, we have one poll question where I would also request everyone just to give one key takeaway message from the breakout session. Just one key breakaway message from the takeaway from the breakout session. So there is a link here, so you can click on that link, and then you can actually say your one most important takeaway from the breakout session that we have just concluded. All right, so while you are continuing with that, just also to mention that there are two options. One, you can use the link, but also there is a text. You can use the text through the below link as well. So I want to invite the team leads from of the group to provide us feedback. The question that we're responding to was, how do we promote and improve the integration of adolescent health services, integration with the VMMC and reproductive health? So 3 actions to start, 3 actions to stop, and 3 actions to continue. So we have 3 groups. I want people to volunteer. Who is ready to start? Who would like to start? We have the team leads are Simba, we have Christine, and also Julie. So who would like to start to share with us these 3 key important actions?
I think Christine is ready.
Christine, you are ready? So you can actually share your slides and you will have maximum 5 minutes to share. Christine, please go ahead.
Thank you, Fabian. Are you able to see the slides?
Yes, if you can put them in a presentation mode.
I am, okay. Okay, so our group was group 2. We didn't have it, the heading there. Trying to move to the next slide. Okay, so yeah, so we had quite good discussions on the case study that was presented from Zimbabwe, and looked at the 3 issues that we were to discuss. So I'll start just a summary with the key actions that we thought we should start in order to promote and improve integration of adolescent health services and VMMC. Some of these, the key points are also really much related to the challenges that the group members were able to express. So the first one was a lot of people expressed the frustration and the challenge of the consent, age of consent. Most of the countries we know for VMMC to take place, the consent has to be given, and most countries only allow consent at 18 years. We know that there's been some revision of consent in some other aspects of the HIV program, like HIV testing, where we are able to test at even 14 years. But for VMMC, we are not able, most countries, we need consent of the parent or the guardian or somebody who is above 18. So this was something that was expressed by most of the group members, and we felt this is a place that we should start by advocacy of the revision of age of consent policy and looking at the best interest of the adolescent, especially like the adolescent which were able to give consent to some of these services. We also learned of the positive masculinity manual that is being validated. This is something that most countries also do not have. And this is another point that we think that we could start from there. And once the validation is complete, it could be shared for other countries to also learn from this. The assessment of what are the feasible options and the healthcare workers' capacity, which was something we got as a lesson learned from the Zimbabwe case study, that they were able to go on the ground and see what is happening and what were the healthcare workers' capacity, especially for countries that are also moving to sustainability, where we are having reduction of healthcare workers. So we need to find out what is the capacity, what are the capacity needs before we introduce some of these integrated services. Again, I think we had more points on actions to start. The capacity building of healthcare workers and also policymakers on the integration models. We also discussed the need to adopt and adapt the best practices. We don't need to wait for the silver bullet. There's a lot of work that's already going on, and we need to see what works best in our different contexts and start with it. And of course, much related to this is the documentation and sharing of practices, which we felt this was a very good thing that the Zimbabwe case study was able to document this, but we also expressed the frustration and challenge that most of us are doing quite a bit at home, but we have we don't document and share what we are doing, and we need this to also move on the integration and also for helping other countries that are looking for what to do. Actions to continue. We discussed a lot about the services of VMMC to the under 15-year-olds, and we know that we have the new guidance that VMMC is not being provided now to at least the surgical procedure to the below 15-year-olds. But we said that these services for other reproductive services or gender appropriate services should still continue for the 10 to 14-year-olds. We don't need to turn them away without offering any additional services. But of course, linked to this is the issue also of consent, where we still are turning these young boys away because we are still asking them to come with a guardian or a parent. Something that needs to also continue and probably at a larger scale is the wider consultations and involvement of other stakeholders, both within the Ministry of Health and also in other sectors. In the Ministry of Health, the need to involve other units, the sexual reproductive health unit, the mental health unit. We know a lot of mental health issues that we can integrate, and we can tap into the opportunity of our VMMC clients to offer mental health services, and also the M&E units who will help us capture some of the data and indicators that we are from the services that we are offering. Something else to continue, again, related is we should start, but also continue documentation of success and best practices. This is repeated as something that we should also continue. Something that was really also discussed at length was the involvement of the peer educators and the adolescents, which we think was also one of the success factors of the Zimbabwe case study. And we usually kind of leave this, the adolescents themselves as we are developing our programs, and we felt this should continue and be scaled up because they will be able to guide us on how best we develop these programs. Lastly is what are the 3 actions that we need to stop? Unfortunately, we didn't come up with 3, but we had discussions more on the other areas. But one of the key actions that we felt very strongly that needs to stop is the silo programming and silo financing. We talked about how our programs are financed in siloed way, parallel way. Even under HIV, we have money for VMMC, for PrEP, for HTS, and all that. So when we talk about integrating and providing integrated services, we come upon the biggest challenge of the siloed finances, that we are not able to use finances for one program to offer services in another program. I think that's it from our group. Thank you very much, and over to you.
Thank you very much, Christine. On behalf of Group 2, I invite the second lead. Julie, any of you?
Yes, yeah, I can present. I think, Christine, you can stop sharing.
I'm trying to stop sharing. 1 minute.
All right. So I think I've managed to stop you from sharing. So from the first group, I think the 3 issues that we identified as things that we need to continue were, firstly, the use of social media. for interaction with young people. So we realized that this is, I think, colleagues shared from Zimbabwe and also some experience from Uganda and South Africa that young people preferred to use social media, and it was an important platform to ensure that we do not prescribe to young people what we think are the services they need, but we interact with them through social media and they give us their input. We said we need to continue to involve young people in the definition of integrated services through an iterative process, so that, again, we do not say this is integration, but we have the young people indicate to us what they think, what is integrated service. I think we heard from Zimbabwe that young people said they preferred to have all the services in one room with the same service provider, and to them that was the real integration that they wanted. So we need to continue to engage them so that we do not prescribe, but we work together as partners to ensure that we provide the service that is perceived to be of good quality. We discussed in the group that in most countries, in most contexts, it's that preferred package of having the same services under the same roof, sometimes being provided by the same provider, may not be feasible due to different reasons. So we think that in those settings, we need to continue to strengthen the referral pathways between the different service providers, the different stakeholders, the different facilities, so that young people are not lost between the two facilities, and that we continue to engage the young people again in that, in defining the referral pathway, and also in continuing to strengthen the pathway. In terms of things that we need to start, we indicated that, for example, in Zimbabwe, we've heard that this project has been implemented in a few districts for quite some time. So we need to really start thinking about how we bring those interventions which are promising to scale to attain national coverage. And we've said that in those countries where this has not started, to identify funding which can be used for this first implementation of the integration services. We also heard that from that in other countries, in other settings, the setup of the facilities is not friendly for the youth people, for the young people. So the facilities are really, I think they were designed for sick people, and this makes the facilities unattractive for young people. So we need to think about how we need to rethink about the setup of our facilities so that the young people are accommodated. We also discussed about the M&D systems, and in most settings that the integration, the indicators for monitoring integration are not included in the national M&D systems. So we need to think about defining these indicators and having them included into the national M&D systems. We had a fourth action that we need to start, which is something similar to what Christine has already presented about innovative capacity building models for healthcare workers. Like we indicated from Zimbabwe, that one of the biggest drivers of the cost was this capacitation of health workers, particularly at the beginning of the project. And we're thinking about how we can incorporate this integration of VMMC and SRH, HIV and SRH within the pre-service training, within the curriculums of the different types of cadres, so that by the time that they are going out to work, they are already prepared and we don't need to continue to invest again in capacity building. We came up with 3 actions that we think are priorities that we need to stop. Firstly, the vertical implementation of integration interventions. So we had, for example, from Zimbabwe, that the SRH project program is a vertical program, the VMMC program is a vertical program, and sometimes when people want to introduce this integration, it's again introduced as a vertical program. So we need to think about how we can build systems that are resilient, systems that are strengthened, thinking about taking a more horizontal rather than a vertical approach. We discussed about the issue of young people with disabilities, and it came up that in most settings, these are totally excluded from the programming. So the IEC materials, for example, they are not friendly for them. We do not have IEC materials for young people with visual impairment. Even the demand generation approaches, that we do not accommodate these young people. So we again need to think about how we should stop this exclusion of young people with disabilities and other vulnerable young people to ensure that they are included in our programming. Thirdly, we discussed about bringing these interventions in such a way that they are perceived by the country as something that is coming from outside, maybe something that is driven by donors, so that at the end of the day, there's really little of no country ownership, which ultimately affects the sustainability of the intervention. So once the funding is no longer there or is reduced, then we see also that the intervention naturally dies down. So what we said, we need to stop implementing these sort of activities which are perceived as coming from outside, but continue to involve the countries in the design of the program, the implementation, the evaluation, so that they feel that they own the programs. So thank you very much. That's the contribution from Group 1.
Thank you, Simba. That was really very comprehensive. So let us go to the last one. Julie, can you share your screen?
Yes, I'm just trying to share it now. Is it coming up? Not yet.
No.
Yeah.
Do you see it?
Yeah.
Okay, great. So Group 3 had very good discussions, quite a few on the challenges, and then we moved into these actions. The three, we have more than 3 on each of these. So for the actions to continue, it was that there are currently situation assessments for adolescent health more broadly that are done in countries, and there needs to be the inclusion of HIV and the packages for prevention and treatment of HIV and AIDS. Secondly, there needs to be a costing of adolescent health services, including the components we've been talking about. Thirdly, the need to ensure ownership by adolescents, and it was mentioned there are tools to support this, and I think good examples from what we've heard from the others. And fourthly, to continue research as showed in the presentation, which helps to understand the value of and the effectiveness of a particular approach. So I'm going to move on to the actions to start. And these included increasing domestic funding for HIV for reasons we've heard from others, to develop an intercollaboration framework for the technical working groups that focus currently separately on SRH and VMMC, and perhaps other technical working groups. Thirdly, to enhance the core training of healthcare workers, both service providers, but also program managers, on these 2 areas so that they are able to understand them and to take them forward together. Fourthly, to ensure that the national adolescent health policy and program, which exists in most countries, also includes MC, and also strategies and plans include the MC intervention. Fifthly, to monitor the effectiveness of referrals and I think other aspects of service delivery. Fifth, to have high-level advocacy to ensure the needed support, including that support from partners and donors who may have different priorities and may have a siloed perspective. And then to start in schools with sexual reproductive health education, which is then reinforced by healthcare providers. And then 3 actions to stop, actually 4, is to stop the standalone documents. And there were examples of this, for example, the healthcare competencies. This should be embedded within the whole package of competencies. And there were other documents with which others in the group could clarify better. To stop the focus on the indicator mainly of the numbers of MCs performed only, rather than the other services provided, including, for example, the education that's provided to adolescents and men. To stop the over-reliance on a top-down process rather than the bottom-up process of planning, and which leads to more autonomy on the ground. And fourthly, to stop focusing on only the one intervention. And so that was our group. And I'm sure they have other things to add, correct, as they were very articulate in their comments. So thank you very much to the group. And I will stop sharing now.
Thank you so much, Julie, and thanks to all the team leads and the participants for really very successful group work and the little discussion. We had requested people to come up with just 3 actions under each of the subheading, but I think based on the intensity and the comprehensiveness of the issues, groups came with so many actions really to follow. So thank you very much for that. I think these slides will be available to many of you. And I think now, let me move to the pause that we have actually done. Number 1, I want to share these results so that people can see. This is number 1. In your country, how do you rate the progress towards the integration and the linkage of adolescent sexual reproductive health and the VMMC services? So you can actually see that majority of our countries, 50% actually, they're still at early stage, and 44% at intermediate, only 6. That is 2 people, 2 countries, they are at the advanced level. So we can see that, 94% of little countries needs to put things on the ground. So that is number 1. And then the second one was what are the key takeaways from the breakout discussion? I'm not sure whether, okay, these are, I think, key issues that are coming out. Is it possible to? Is it possible to get a screen or a slide for that? Colleagues from the ECO IT?
Great, thanks. Thanks, Fabian. Here it comes.
Oh, here it comes. Oh, thank you so much. So these are key issues that are coming out. Ownership from adolescents, young people, and residential communities, and crucial to service acceptance and access. Policy considerations and need for flexibility of donor funding beyond core indicators. Okay.
Unish, yeah, Unish, can you keep scrolling so we can see?
Yeah, I'm trying to scroll down.
And we need Unish to do that for us. Great.
Can you scroll down for me, please, if possible?
Yeah, just give me a moment. Sorry, just give me a moment. I think some issue was there.
All right. Perhaps I can, while we are trying to find out how we can bring that to the screen, I can take this opportunity to invite our another important colleague. Is that done?
Yes, it is done now.
Okay, all right, okay. So let us start from the beginning. All right, so what are your key takeaways from the breakout discussions? So from the top, just start from the top. So that
we can just wait and we can start from the top now. Yeah, just a minute. Actually, the responses are coming. Then we can just start from the top.
Oh, I see. Okay.
It might be easier to start from the bottom, actually, and work your way up.
All right. So okay, I can see a lot of responses here. That's high-level advocacy from donors and Department of Health, as well as adaptation of VMMC. SRH indicators is a key for successful integration, that it is feasible and practical to provide integrated VMMC and SRH services, all right? So those are one of the two key. Next.
So Unish, just gradually scroll up so that Fabian can read them as they come down.
Okay. Linkages and integration is central to sustain adolescent health program. Move up again. We need to think about how we deal with young adolescents, 10 to 14 years within the integration framework. Another key important message. Up again. We need adopt the M&E system to monitor integration indicators. Documentation and publication of intervention is critical. Up, up. We need to move away from silo mentality when providing services, especially from a funding perspective and from the health system provider. Yes, another one, up. A high-level advocacy on VMMC, SRH integration among donors and the Ministry of Health. Up. SRH is very critical and service providers are eager to offer, unfortunately, need support from stakeholders, mainly donors. Therefore, there will be set indicators to track monitoring and performance. Up. Then Zimbabwe should clearly document its experience and share widely so that other countries do not have to reinvent the wheel, but build on from rich experience. Very good, yeah. Up. Continue. Need to address the research gaps between VMMC and ASRH. Integration of SRH and VMMC. Up, up. Project provide good and important evidence on a practical actions that informs country policy and strategy on integrated adolescents health package, including SRH and HIV. Up. We're almost there, finishing. Continue up. Wow, that's quite a paragraph. That is feasible and practical to provide integrated VMMC and SRH services. Second, we need to move away from the silo mentality when providing services, especially from a funding perspective and from health service provider. Zimbabwe should clearly document this experience and share widely so that other countries do not have to reinvent. I think I've read this before, but maybe it's quite good to repeat, okay? Right, and then policy considerations and need for flexibility of donor funding beyond core indicators. Up, I think these are the last ones. Ownership from adolescents, young people, residential communities, crucial to service acceptance and access. I think that's the last one. So there are really key themes that are coming from this: issues of preventing silos, funding, issues of the documenting the experience, sharing with other countries, and really engaging young people. So these are really themes that are repeating from what colleagues have really discussed from the groups. Really, I have to thank all of you for such wonderful feedback from the group work. Let me now invite Sinokutemba Ngaba, who is the National Male Circumcision Coordinator from the Ministry of Health and Child Care in Zimbabwe, to really provide your final reflection on this webinar. Sino, please, you have the floor for 5 minutes.
Thank you very much, Fabian, and good afternoon, and colleagues. Thank you for this opportunity for us to just go through this webinar together. I would just like to take a few points for consideration as we, I think, near the end of this meeting. For us as Zimbabwe, this has been a very great learning experience, because we note that about 40 to 50% of our VMMC clients have been actually in the age group of adolescents and young people. And this is the first time we've had a program that actually reaches to so many males outside the EPI or the vaccination program. But the point to note is that while we reach to so many, we know that generally men tend to have a poor health-seeking behavior. Even in our own context as Zimbabwe, men, even in the ART program, they tend to come late for services and so forth. Yet, we have a program that has generated this pool of men, bringing them in contact with the health system. So we see an opportunity where the VMMC program can actually be an entry point for a change of culture for men in terms of accessing health services. So it is important, therefore, that this linkages work that has been initiated could actually be rolled out and scaled up. I think when I look at the data from other countries as well, the priority countries for VMMC, it is also the similar trend that very high numbers of the clients circumcised are coming actually from this age group of males. And it is at the time when the males are at their healthiest, they have no problems, they're actually healthy, they are coming into a health sector or into a health system. So I think we need to maximize the moments we have with them and start inculcating this culture of appreciating their health in a different way and in a better way. At the same time, we also then need to wire up our health services so that they are actually responsive to the needs of the boys and the men overall. So as we continue to scale up the VMMC program, we see great opportunities where we actually even start challenging some of the masculinity issues that actually drive the HIV epidemic and that also drive other problems that we face in the HIV space overall. As I look at the ASRH program within our context, it's a program that's been running for quite a number of years now in this country and has profiled quite prominently the issues for girls in particular, girls and young women. Even we have the DREAMS program that we're actually implementing. So we also see an opportunity where now we can even further tie and strengthen these linkages between these two programs. But beyond that, it has also opened avenues for greater collaboration with other government and non-state actors. For instance, the Ministry of Education that houses the young people and boys, the Ministry of Youth in some countries, like in our country, who are actually the core ministry responsible for young people. So I conclude by saying I think we have a great opportunity with the lessons that we are learning from this project. It can actually open bigger avenues for us to help our men, our young men, and our men overall to actually start adopting more positive behaviors, especially at the time when they are healthy. It will make it easier when they are actually ill or facing challenges in life to actually be familiar with the health system. So in our linkages program, I think our presenter mentioned that over 30% of the clients who actually went for SRI services were actually referred and actually took up VMMC services, and over 33% also vice versa. So which shows us the greater opportunities we have, and we can link with other services. We actually would do our men folk a greater good through this entry point of VMMC. So I'd like to thank WHO and also the teams that have funded this pilot project over the initial phases, and also as we generated the lessons. Thank you so much, Fabian, and thank you, colleagues who have participated in this project over the years. Thank you. Over to you.
Thank you so much, Sino. I think, yes, VMMC presents a lot of opportunities for linkage and also integration for other services. Now, the link has been provided in the chat. For those who want to get the certificate of attendance, you can actually click to the link, and there is a 2 minutes survey that you need to fill in, as I said at the beginning, so that you can actually get your certificate. I think now this brings us to the end of our webinar. Let me close the session by really, number one, thanking all of you for your attendance, but also very great participation and active engagement in this webinar. Number two, also I thank all the presenters and also partners, but also organizers of the session and also donors to the program. But also I thank the ECHO team for making this session really very, very interactive. We are hoping that these lessons that we have learned today from this project will translate and become the community of practice to learn and also share information and knowledge towards improved service integration for adolescent health. Again, you may be aware that the integration of services is well recognized at higher level from global, region, national level, and is also well recognized by both partners and donors. Those who had an opportunity to look into WHO Global Program of Work 13, integration has been identified as one of the vehicles to deliver the 3 billion targets. So it's really very important that integration is taken serious, but also taking these lessons that we have learned from this project, really to put them into ground. The regional office, Afro Regional Office, HQ, and partners are committed to continue working with all of you as we will consider to introduce and scale up the integration of services, not only for SRIH and the VMMC, but with other services as well in general. And I would really request that you should not hesitate to reach out to us to really, if you need any support from this level, but also across countries, as Zimbabwe now is a pioneer in terms of getting ground experience for this integration. Having said that, I thank you again for the active participation, and this brings us to the end of this webinar. Thank you and have a good evening, good afternoon.
Thank you. Goodbye, everyone.
Thank you.
Bye.
Bye, everyone. Be well. Thank you.